Does the higher dose make Wegovy the new winner over Zepbound? Wegovy now reaches 7.2 milligrams, while Zepbound tops out at 15 milligrams. High-dose Wegovy produced 18.8% average weight loss in its own trial. That result makes high-dose Wegovy more competitive, but it cannot prove the drug has passed Zepbound. The higher dose changes the contest without making the drugs identical or establishing a winner. Wegovy contains semaglutide and copies one gut signal that helps create fullness after eating. Zepbound contains Tirzepatide and copies that signal plus a second food response signal. Both reduce hunger and help smaller meals feel satisfying. Raising the semaglutide dose strengthens the same signal without adding Zepbound's second signal. A higher dose can narrow the outcome gap without matching Zepbound's design. The clearest direct comparison used standard Wegovy, not the new high dose. After 72 weeks, people taking Zepbound lost 20.2% of their starting weight on average. People taking Wegovy lost 13.7%. Zepbound produced about 6.5 percentage points more average loss. However, Wegovy in that trial could only reach 2.4 milligrams. The newer high-dose study tested 7.2 milligrams against 2.4 milligrams and placebo. Adults without diabetes lost 18.8% on the high dose. Those taking 2.4 milligrams lost 15.5%, making the added benefit about 3.3 percentage points. For a person starting at 250 pounds, that average difference equals roughly 8 extra pounds. It is large enough to matter, especially near a treatment goal. It is not large enough to assume every patient should increase. The result describes a group average, not a guaranteed personal outcome. The percentage targets show the same pattern. Nearly 64% of people on high-dose Wegovy lost at least 15% of their starting weight. About 46% lost at least 20%. Standard Wegovy reached those targets in about 52% and 32%. So the higher dose moved more people into deeper weight loss ranges. Zepbound's separate obesity trial reported 20.9% average weight loss at 15 milligrams. That sits slightly above Wegovy's 18.8%, but this is not a direct comparison. The studies enrolled different groups and used different designs. A direct comparison gives both drugs to similar participants under the same rules. Separate trials can differ in starting weight, diabetes status, dose schedules, follow-up, and how missing results are counted. Milligram numbers cannot be compared directly because the drugs work at different dose ranges. No trial has directly tested Wegovy 7.2 milligrams against Zepbound. The older trial found more loss with Zepbound than standard Wegovy. The newer trial found more loss with high-dose Wegovy than standard Wegovy. Together, those findings suggest a possible Zepbound edge, but they do not establish a direct winner. Group averages can hide wide differences between individual patients. One patient may respond strongly to Wegovy and weakly to Zepbound. Another may experience the opposite. A drug with the better average can become the worst personal choice when side effects or access interrupt treatment. Dose escalation should therefore depend on the patient, not the trial ranking. Wegovy's high dose is not a new starting dose. The 7.2 milligram dose may be considered after at least 4 weeks at 2.4 milligrams. Extra loss should serve a medical goal, while the current dose remains tolerable. The practical goal is the lowest dose that delivers benefit without making treatment harder to continue. Side effects become more important as the Wegovy dose rises. Nausea affected 39% on 7.2 milligrams and 35% on 2.4 milligrams. Vomiting affected 22% and 16%. The higher dose added weight loss, but it also increased some stomach-related problems. High-dose Wegovy also produced altered skin sensation more often. People reported burning, tingling, tenderness, or unusually sensitive skin. This occurred in 22% on 7.2 milligrams and 6% on 2.4 milligrams. Reducing or pausing the dose often helped, although some symptoms continued through the trial. That extra skin effect does not make Zepbound side effect free. Zepbound commonly causes nausea, diarrhea, constipation, vomiting, and abdominal discomfort during dose increases. Its maximum dose is not automatically easier to tolerate. The useful question is whether either medicine allows regular eating, drinking, activity, and weekly dosing without repeated disruption. A stronger average means little when vomiting. Dehydration or missed doses prevent consistent treatment. Diabetes is another patient-level factor. In adults with obesity and type 2 diabetes, high-dose Wegovy produced more weight loss than 2.4 milligrams. The extra improvement in A1C, the 3-month blood sugar measure, was small. The higher dose added more weight loss than blood sugar improvement in that study. The higher dose should not be viewed mainly as a stronger diabetes treatment. Better trial averages matter less than the weight loss needed for a meaningful health goal. Starting weight and existing disease shape that target. Someone needing 10% may succeed before reaching either maximum. Someone needing 20% may value a stronger average, but only when the dose remains tolerable. Carefully judge the response already happening before chasing the maximum dose. Hunger, meal size, waist measurement, and weight trend should improve during dose increases. A person losing steadily on a comfortable dose gains little from increasing further. Increasing too quickly can exchange reliable progress for nausea, dehydration, and missed doses. A real plateau also needs enough time to identify. One flat week may reflect salt, bowel contents, or normal daily water shifts. Several weeks without weight or waist change provide better evidence. If appetite control has also weakened, increasing the dose becomes more reasonable. Changing drugs becomes more reasonable when response stays inadequate despite a tolerated dose. Medical goals can break a tie. Wegovy has an approved role in reducing heart attack, stroke, or heart-related death for adults with established heart disease. That benefit was studied with lower doses, not specifically 7.2 milligrams. The 7.2 milligram dose should not be chosen solely for that heart benefit. Zepbound is approved for adults with obesity and moderate to severe obstructive sleep apnea, which repeatedly blocks breathing during sleep. That can favor Zepbound when sleep apnea is a treatment target. Even then, every patient does not need 15 milligrams. Response and tolerability determine the useful maintenance dose. That approved use can guide the drug choice without automatically determining the maximum dose. Reliable access can still outweigh trial averages. A drug that costs too much, disappears from pharmacies, or loses insurance coverage cannot deliver lasting results. Stable access to the second-choice drug often beats irregular access to the trial leader. Repeated stopping can return hunger and promote regain. The decision becomes clearer after 4 checks: needed weight loss, tolerated dose, actual response, and reliable access. Until a direct high-dose comparison exists, Zepbound has stronger evidence because it beats standard Wegovy directly. High-dose Wegovy makes that advantage less certain, especially when semaglutide already works well. Escalation is most reasonable when more loss is medically needed and the current dose remains tolerable. Slowing progress or weakening hunger control can strengthen that decision. Switching makes more sense when response stays inadequate or side effects block useful dosing. The higher dose changes the contest without proving a new winner. Zepbound keeps the strongest direct result for average weight loss. Wegovy 7.2 milligrams becomes an alternative when semaglutide already works, and more loss is medically useful. The practical winner is the treatment that reaches the needed health target and can be continued. Maximum dose is not a goal by itself. Durable hunger control, manageable side effects, and reliable access matter more than winning a percentage contest on paper. Medicine simplified, that's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.